So the management of lung neuroendocrine tumours. So those are my disclosures. Okay, so the management topics that I'm going to cover are topics that I often get asked in clinic. So there's no rhyme or reason to this, but I'm going to cover post-surgical adjuvant state, okay, who gets treatment and who doesn't, carcinoid syndrome, very quickly, and then the mess that is treatment of systemic disorders, okay, and I'm going to cover certain systemic treatments within that. And then I really want to spend some time on a single slide, hurdles to getting new treatments in the lung net sphere. I want to spend a bit of time on that because this is what really needs to be understood. Okay, so let's go. So adjuvant therapies, therapy or not, why are most people not offered this in clinic? Okay, so some of you may have seen this slide before, but it's simple, this bit, okay? So we are, as medics, are dictated to by a classification called the TNM classification, which you can argue may be good or may not be good. Okay, some people like it, some people don't, okay, but essentially what that tells us is that there is an increased risk of relapse when you go in a certain direction within this classification. So when you have a small cancer versus a big cancer versus lymph node involvement, okay, you increase your risk. And you can throw into that with neuroendocrine cancers, the histological type. So typicals have less chance of relapse and atypicals have less chance of relapse in this new group called the typicals, okay, but key to this is increasing lymph node burden. And so you'll see in the men that I've drawn in the diagram that I've put a red square around the cancers that CT scans can visualize, but you'll see that these patients also have these little blue dots around their bodies, and those are what we call micrometastases, and that's really where the battle lines lie. Okay, so to explain that a bit further, when a person has been diagnosed with a local cancer, so that's signified by that green blob, okay, the surgeon will go in and operate on that green blob, but unbeknown to the surgeon and to anybody, you can see those little black dots which are pointed to by an arrow. That's micrometastases, and unfortunately there is no way of detecting micrometastases with today's technologies. Okay, so you can, so we know that when a person has micrometastases, their body is working quite well. Their immune surveillance isn't giving us clues. There isn't any early genomic dysregulation that we can pick up. The cytokines, the poisons that the body secretes when a person has an advanced cancer aren't being secreted, etc., etc. Radiology isn't picking up this disease. Neither is biochemical testing, and so there is no method of early detection. By the time those cancers grow into something that is visualized, it's too late. By that time, it's late detection, late intervention, worse outcome. Okay, so that's really what the thrust of the question about should adjuvant be given or not circles around. So without any method of early detection, what we have to do is use our cunning and work out which patients are more likely to relapse. And I've kind of intimated that in my earlier slide when I looked at the TNM classification. But essentially, histology is a no-brainer. We know when a person has an atypical neuroendocrine tumor, they are much more likely to relapse than when they have a typical. And this is what we call a Kaplan-Meier curve, and you're going to see a few of these. As the I don't know whether you can see my arrow, but as the graph falls, so if you look at the ACs, which is the bottom line, it falls faster than the TCs, the typical carcinoid, and that's because patients are sadly dying faster. So each time a patient falls, the line falls. Okay, and so it is heading towards zero much faster than the typical carcinoid, and that's what we call a Kaplan-Meier curve. Okay, so the more horizontal a curve is, the higher it is, the better. And you can see atypical carcinoids don't do as well as typical carcinoids. What else is a certainty is lymph node involvement. If you have no lymph nodes involved, you do better than if you have lymph nodes involved. Okay, so we know this now. So these are what we call two factors that in what we call multivariate analysis stand up. Okay, so if we are going to offer anybody adjuvant treatment, these are the two types of factors that we should consider. So what is adjuvant chemotherapy trying to prevent? Well, we know that typical carcinoids, about 80 to 90% of patients with this type of carcinoid are resectable. And we know that with atypical carcinoids, about 50% are resectable. And we know that when a surgeon resects these cancers, then about 5 to 10% of typical carcinoids can relapse, but almost 50% of atypical carcinoids can relapse. And so what we're trying to do is prevent this from happening, this relapse pattern. We know that these cancers like to go to the liver, the lung again, lymph nodes, bone, and other parts of the body. So we're trying to head this off at the pass. And the only way we can do that is by giving systemic therapies or even radiotherapy earlier on, just after the resection, to see if we can stop that from happening. So why don't we offer this to all patients with lymph node disease or with atypical carcinoids? Okay, well, firstly, we use guidelines to help us. And if you look at the ENETS guidelines, the NCCN guidelines, and the NANETS guidelines, and these are European and American guidelines, none of them agree with each other. Okay, so the ENETS guidelines say one thing, the NCCN guidelines say another thing, and the NANETS say we don't recommend it at all. Okay, so why is that? So if you look at evidence base, that gives you the answer as to why the guidelines don't agree. So the evidence base for neoadjuvant chemotherapy, so that's therapy before a surgical operation is done. Okay, so a lot of cancers we deal with neoadjuvant treatments before the surgeons get to them. That just simply doesn't fit into this pathway. Okay, because lung nets, as you will know, are often diagnosed as incidentalomas or are diagnosed after surgical resection. They are rare cancers, so we often don't know that's what we're dealing with before the surgeon puts scalpel to skin. So neoadjuvant chemotherapy we can scrub out. Adjuvant therapy, however, there is a possibility that we could introduce this, because once the surgeon has removed the cancer, then treatments are available. Okay, but when you look at the evidence base, it doesn't stack up. Okay, so there are many retrospective, so not prospective studies that have been done. These are 3 examples, and you can see that the number of patients in each trial is tiny. You can see that histologically they are all atypical carcinoid, which is the correct histology, but it's the wrong chemotherapy. Okay, this is not the chemotherapy that we use for well-differentiated lung neuroendocrine tumours, and as a consequence, the survival data is all over the place. So we don't get an answer from the evidence base that we have. So really what this needs is a prospective trial. So in terms of prospective adjuvant studies, you firstly have to select your patients. Okay, so who will relapse? There's no point giving chemotherapy, and you mustn't give chemotherapy to people who are not likely to relapse. So you have to identify the patients that are going to relapse. And I've just mentioned lymph node positive cancer patients and patients with atypical carcinoids. Okay, so you've got your cohort of people that might relapse. You then have to pick the adjuvant therapy. Okay, and this is where the problems start. The adjuvant therapy is picked often from people that have already progressed and have stage 4 cancer. That's where we know which chemotherapies work best. Okay, you have to choose a chemotherapy that is highly responsive. Okay, no point picking a chemotherapy that can't mop up those micrometastases. And our answers as to which chemotherapy should be used, we don't know. We don't know which chemotherapy we should use. Equally, toxicity profile, what you mustn't do is give a person toxicity that they have to carry with them for the rest of their lives for the sake of trying to prevent a cancer possibly from reoccurring. Okay, so we mustn't give disability, so you have to choose a chemotherapy that has a good toxicity profile. Okay, so that's part of the problem, but the main problem is in study design. In order to design a study and get the funding for it, you have to do something called a power calculation, where you have to work out how many patients you need to find a difference between 2 groups. And the 2 groups would be one group that doesn't have any adjuvant treatment and another group that has adjuvant treatment post-surgery. okay? And you have to find out how many patients you have to recruit to define a meaningful difference. And the problem with that is, if you don't know what the effect of chemotherapy is, you can't define that, okay? The other problem with study design is accrual rate. Because these are rare cancers, and I'm now sub-picking even rarer parts of these cancers, so atypical carcinoids occur 8 times less than typical carcinoids. Typical carcinoids are rare, okay? You have to make sure that you accrue, you recruit to the trial, because it's expensive running studies. So nobody's going to fund a study that's going to run for 20 or 30 years, okay? They want some guarantee that you're going to finish this study within 5 to 10 years. And then there is event rate, okay? So when you pick a group of people, then you do have to pick a group of people that will give you your answers, okay? Relapse, okay? If you pick a group of people that will never relapse, you're never going to get an answer. So you're never going to be able to publish. So picking the right patient is very important. And this is where conversations have got stuck. We don't know how to recruit to a trial like this, okay? And so that's why when you go up and down the country, different people offer you different things. Most people won't offer you adjuvant treatment. I do give adjuvant treatment, and I have given it to selected patients based on what the patient wants, but also on risk of relapse. But I have no idea whether I'm doing them any good. Okay, so next bit, medical management. So what are the general principles? Okay, generally, we are always going to be concerned in the non-curative state, okay, that we have to accept that when patients get to stage 4 cancer, they are in a non-curative state, and therefore survival and quality of life become very important. And there are 2 ways that this can work, okay? So bronchial nets, we know, small proportion of patients are secretors, and an even smaller proportion of those patients, I've said 25% in lung neuroendocrine tumours, it's only about 5 to 10% of patients are actually secretors, okay? And then the larger cohort of patients are non-secretors, okay? So in the secretors, we have to control their carcinoid syndrome, okay? And there is a developed evidence base for this. In the non-secretors, which is the large cohort, the bigger group of people, there is very poor evidence in how we treat those patients, and I'm going to go through that. Okay, but before I do that, let's quickly go through carcinoid syndrome. So there are many syndromes that a person with a lung neuroendocrine tumor can develop. Okay, and these are some of them, but the one that I've highlighted in red, carcinoid syndrome, is the one that we're going to talk about. And like I've said, 1 to 5% of patients develop this. Okay, it tends to be a bit more aggressive in lung neuroendocrine tumors than in bowel neuroendocrine tumors. And without boring you too much, this is the pathway. Okay, so essentially, tryptophan is an amino acid, and normally this goes to make a protein or another amino acid called thiamine, and thiamine goes off to our nerves and sorts our nerves out in terms of conduction pathways, okay? And if you become thiamine deficient, you develop nerve disorders, okay? But in patients with syndrome, what can happen is that the tryptophan, it can get diverted into another pathway which produces this thing called serotonin, okay? And the serotonin is a byproduct of tryptophan being converted to thiamine. But serotonin is a fibrotic agent, and that goes around your body causing various well-documented symptoms. So as it courses through your body from the cancer, it can cause fibrosis of your valves in your heart, it can cause lung fibrosis, it can cause flushing and diarrhea. And if you leave that to do its damage, then it will cause heart damage, it will cause pulmonary, so lung damage, and it will cause bowel failure eventually. So it's important that we try and stop that. And sometimes some people get it so severely they end up with carcinoid crisis, where they get torrential diarrhea, they get blood pressures that go high 1 minute and then low the next minute, and eventually their hearts go into funny rhythms, okay? And you can end up with cardiac decompensation. It's very important that we try and avoid that. So how do we treat this? So we treat carcinoid syndrome, as you know, with somatostatin analogues, and there are two leaders in this, so octreotide, LAR, and lanreotide. I'm fully aware that nowadays we use biosimilars, but essentially these are the agents that those biosimilars are based on. And you'll notice that the symptomatic relief, we get it in about 3/4 of the patients, but that still means that between 25% and 33% of patients, we get inadequate symptomatic relief, okay, and biochemical control. So what do we do with those patients? So if you go back to that pathway again, then recently there's been a drug that's been developed through a trial called Telostar, called telotrestat, and this drug stops that enzyme, tryptophan hydroxylase, okay? And so in a world where commissioning didn't exist, the way that we would treat a person with carcinoid syndrome would be, we would start them off on an octreotide infusion or injection, convert them to a somatostatin analog to get perfect control. But if we didn't get perfect control, then we would give them telotrestat. Telotrestat, unfortunately, didn't get its NICE approval, so we don't have that to our disposal. So we still use somatostatin analogues, and then if a person gets carcinoid syndrome beyond that, we use other agents to try and control that. Okay, so now we get onto the slightly thornier issue, which is systemic anti-cancer therapies. Okay, and so I'm going to cover somatostatin analogues again, chemotherapy agents, agents like everolimus, and potential new agents, and then a guidance on sequencing. So once again, evidence is generally lacking here as well. So here's an example of how sequence works. Okay, so when a person presents, you have a choice. You can observe that patient without doing anything, and that is entirely reasonable for some patients. You can undergo surgical debulking for that patient, try and rid them of much of the cancer that's producing the carcinoid problem. You can put them on a somatostatin receptor analog, or you can give them everolimus when they don't do well on the somatostatin receptor analog. So that's fairly linear. But beyond that, there is a lot of confusion. Okay, there are lots of therapies, some of them with very little evidence, that people use in all sorts of sequencing. And this is, I think, part of the problem with lung neuroendocrine tumors. Because there is no sequencing, and then when a person relapses again, there's even less sequencing. Okay, and trials, well, I don't know where they fit in. They fit into big centers wherever we can, but there is no sequencing here. And I think that causes a lot of white noise in signaling. And this is the bit that clinicians really need to clear up. So let's start with somatostatin analogs. So I've already said octreotide and lanreotide, they have the same class effect, okay? And they are indicated in gastroenteropancreatic neuroendocrine tumors. They're not really indicated in lung nets. That's because we've never really found the evidence in lung nets. Okay, but why do we use them for a cytoreductive effect? Why do we use them beyond carcinoid syndrome? So in trying to control the cancer from growing, well, this is where we get the evidence from. When we looked at patients between 1973 and 1987, so this was pre-use of any of these somatostatin analogs or octreotide drugs, the survival for patients on average was about 18 months. When we looked at the 1988 to 2004 cohort, so this is when we started using these drugs in patients who didn't necessarily have the syndrome, we suddenly noticed that their survival was getting longer. So that led to two important studies, the PROMID trial and the Clarinet trial, both looking at either octreotide or lanreotide in non-lung neuroendocrine tumors, and they both showed efficacy in terms of progression-free survival. And so as a consequence, they got a license to be used in patients who didn't have the syndrome. That's where it comes from. Now in lung nets, we try to get the evidence, okay, but in lung nets it is generally lacking. So we try to get the evidence using the trial that I've labeled maintenance of SPINET. Okay, so this really highlights the problem with lung nets. So this was a good study. We were recruiting to it, but the world failed to recruit adequately to it. So the trial had to stop because of poor accrual. And that's what happens with rare cancers. It's often difficult to keep a trial going. Okay, but the somatostatin analogues, there are a number of other research projects going on, and sadly, pasriatide, which is a drug that I was involved with, which was a very effective drug and seemed to be better than both the lanreotide and octreotide, that its program was shut down by Novartis without warning, really. Okay, so what about chemotherapy? So once again, the evidence is lacking here. Okay, but who do we use chemotherapy on? Okay, so we use chemotherapy on people that have failed other therapies, mostly somatostatin analogues, okay, or the mTOR inhibitors. We use chemotherapy on people with advanced histology. So especially the grade 3 nets, the well-differentiated grade 3 nets, okay, but the atypical nets are more likely to get chemotherapy than the typical nets. We use chemotherapy on people with a high Ki67 score. And I've highlighted high because that definition of what a person deems high is different for different practitioners. We use chemotherapy for rapidly progressing cancers, okay, so people that come with lots of symptoms and lots of burden of disease. Sometimes you need chemotherapy to try and cytoreduce that, and we certainly use it on symptomatic patients. And of course, I've put patient choice there because very occasionally we do get patients that say, look, can I have chemotherapy first? But importantly, we use chemotherapy when there is an oncologist interested in pulmonary nets. Okay, so there are situations up and down the country where people don't get access to chemotherapy because there isn't the right practitioner there. The practice is largely based, however, on pancreatic nets. So the current flavor of the month is temozolomide and capecitabine. Okay, so this seems to be the most promising treatment, and this is something that we use at the Christie. It seems to be reasonably well tolerated. Okay, some people in this audience may disagree, but it is reasonably well tolerated compared to what we have otherwise. But most importantly, it has a very good, what we call disease control rate of about 70%. So if you give this to 10 people, in 7 people, it will arrest the growth of the cancer. But there is no survival data available for this. And so the reason for that is because of small numbers of patients that we're using. Okay, and that's because most of these are single center studies because we are not coordinated in doing bigger studies for this type of treatment. What about immune therapies and targeted therapies? So I'm going to use one good example and one bad example. I'm going to start with a bad example, and that's immunotherapy. Okay, so this is how researchers should never do things. Okay, so immunotherapy was tried many years ago. Okay, but the problem was that the trials that we did were small in number. Because they were small in numbers, so the powering was not right. We got variable results. Because we got variable results, they never took off as bigger studies. Okay, and so interferon, which we used to use in the earlier years, 2000s, 90s, and 80s, never really took off. And because that didn't take off, the preceding immunotherapies have not really taken off either. There's no consensus of agreement. But I will say that with immunotherapies, the biology doesn't really sit right with this particular cancer for immunological reasons. So I'm not surprised that immunotherapy hasn't really taken off with this cancer. Now, this is a good example. Okay, so this is how we should be bringing drugs into the lung net arena. So everolimus was introduced through proper evidence base. Okay, so Radiant 2 was the first trial that looked at everolimus in lung nets, but it was just exploratory. So we just thought, okay, let's throw a few lung nets in here and see whether we get a signal. When we got a signal in 10% of the patients, only 44 patients were lung nets in this trial. When we got that signal in the next trial, Radiant 4, we didn't do an exploratory analysis. We said, let's put lung nets into this. Okay, and a third of the patients were lung nets, and we got a signal again. And because we got that signal, we then ran the LUNA trial, which was only for lung nets. And these trials, especially Radiant-4, rewarded us, because what that allowed us to do is get a consensus agreement that everolimus is an effective drug, and that led to NICE approval for lung nets. And this is the only drug that is actually NICE approved for lung nets. Okay, but that's because the evidence base was well worked. What about PRRT therapy? So there are many types of radiation-related targeted agents that you can use in PRRT, and I've listed some of them there. And they work by either throwing gamma rays or beta rays at the cancer by targeting the somatostatin receptor. And currently, the evidence base suggests that the lung nets are probably the ones that don't respond particularly well to PRRT, but they do respond, and you can see that here. The median progression-free survival for the lung nets was 11 months, whereas for pancreas it was 20 months. The median overall survival was 40 months, whereas pancreas it was 44 months. Okay. There are 7 studies that report survival and response exclusively for the lung nets, and they do show efficacy. Okay. And so for typical carcinoids, we know that typical carcinoids do better than the atypical carcinoids. So there is an efficacy signal, but without better study design, it's difficult for people to formally commission lung nets into PRRT therapy. So there's work to be done there. So this is just a list of other trials which do show an efficacy signal. Okay. So NICE approval for non-pulmonary nets. And at the bottom there, the OPS 201 is a trial that's trying to address that balance, but we need to recruit or keep recruiting to trials like that. Okay, so I'm going to go back to sequencing now, sequencing of therapies. Okay, so I've already said or intimated in a previous slide that surveillance should never be seen as doing nothing. Okay, it isn't doing nothing. It is actually trying to understand that disease and trying to understand who needs and who doesn't need active treatment. Somatostatin analogues, chemotherapy. Okay, so this is the order that I give treatment at the Christie. So surveillance for the people that are the fittest and where I feel that the cancer isn't going to cause them much problem. Somatostatin analogues for those people who I think probably need a little bit of help. Chemotherapy for patients that are possibly going to run into problems. Everolimus I've put forth, so really this should be post-somatostatin analogues, but everolimus is a difficult drug, I find, and its toxicity profile is often a problem, and I find that with lung neuroendocrine tumor situations, it isn't as effective as it is for pancreatic nets. And of course, trials. If trials are available, we should always be considering trials. And then 6th, I put in red, PRRT, if it can be offered. Okay, it should be much higher up in the food chain, but it won't be until we find the evidence base. Okay, so where a person starts in this hierarchy from 1 to 6 really depends on many factors. Okay, so the aggressiveness of a cancer, can be measured by the Ki-67 score, the histology, the spread of disease, etc. So you may come across your clinician starting you at a point which is different from me. Okay, but for each patient it has to be individualized. Okay. We also have to look at the previous history of response. Okay, so sometimes when a patient responds well to a somatostatin analog or a chemotherapy, we might go back to that. Okay, we have to always consider trials. Okay, because that's important in how we move this cancer forward. Of course, we have to consider what the patient wants. That's possibly the most important thing. And you also have to consider the physician that's leading the care. Okay, because the physicians that lead the care aren't always oncologists, and so I think up and down the country, there is a postcode lottery because of what what the physicians are comfortable with. If you're an oncologist, you're comfortable with chemotherapy, so you start people on chemotherapy readily. If you are an endocrinologist, somatostatin analogue. If you're a radiotherapy physician, it might be PRRT. It's really dependent on where you are. But the good research rewards you with more choice, okay? And this is just an example of the choices that have become available to us all just by through time, through discovery. And it's really important that the LungNet group jump onto this, okay? Because we don't want to miss all the treatments that are currently being offered. And we're not, because as written here, it's a carrot and stick. If you have a good pathway for lung nets, which we don't, okay, then the accrual can be sorted out, because if you have a good pathway, you know that patients will eventually get to you, okay? If you have 100 people looking after you, the people that run the trials think, well, how are we going to get those patients? Because they never get to you. They go randomly to lots of different people. So the pathway is important in rewarding this, okay? But if you run good studies, you will get rewarded by more studies. And then this is what I think strategy-wise we need to improve with lung nets. There are treatments being offered, okay? So currently at the Christie, we are running a trial which I've starred here, sorafenib. It's a phase 2 trial. It's running across Europe, post first line for patients with lung nets. So we're currently putting patients into that. But many trials are running, so it's not all doom and gloom. But we do need to improve our accrual into these trials to get more. Why is immunotherapy not really mentioned here? And I mentioned before that this cancer doesn't fit right with immunotherapy. Well, I'm hoping it will in the future, but currently the results have not been impressive. There is a problem with something called low somatic mutations, because these cancers don't create too many mutations. So there's a problem with getting the immune system to recognize this. And of course, there is an issue with the biomarkers. Okay, they don't get expressed in these cancers, and that's why there isn't much interest in the current immunotherapies, even though there are with other cancers. So this is the slide that these are the two slides that I want to get to. So what is the problem with lung nets? Okay, so this graph highlights the progress that various cancers have made since 1971, when Nixon announced the war against cancer. Okay, and I've gone to 2007, and you can see that gastric cancer is probably the one that's made the least progress. So we call that an orphan tumor. Okay, that's the one that's made the least progress. And that's another cancer that I look after. Okay, so that's why I'm well versed in the problems with lung nets. That's why I took it on. Okay, so gastric cancer is not well researched. Okay, unlike all the other cancers. But when we look at lung net development and gastric cancer development, look at how shocking lung nets are. Okay, so if you look at the gastric cancers first-line therapy, we use a chemotherapy I've called Chemo 1 with level 1 evidence. That means we have meta-analysis and randomized controlled trials, globally accepted, peer-reviewed. In second line, we have Chemo 2, level 1 evidence, global randomized controlled trials. Remember, this is the worst researched disease. Okay, third line, we have level 2 evidence, randomized controlled studies. Fourth, we have level 2 evidence. This is all good evidence that we're basing practice on a cancer that we call an orphan tumor that needs urgent attention. Now, if we look at the lung nets, look at first line, no evidence for what we are using. Second line, level 4 evidence, which means we're really borrowing evidence from retrospective analysis. Okay. Third line, level 4 evidence, borrowing evidence. Fourth line, we have level 2 evidence, everolimus. But you can see where we are compared to all the other cancers and how much work we have to do. So I guess what's important is for you guys to understand how treatments come into the clinical arena. Okay, and this is what this is designed for. So how treatments come into the clinical arena. So you first get a preclinical idea. So this is a laboratory idea which is tested on any cancer, and that's called drug discovery. So this is just in the laboratory. If you get a signal there, it gets peer reviewed and published. Okay, peer review means it gets judged and then put in place, okay, by other experts. If it's got a good signal, you then get that drug developing into phase 1. And once again, this involves any cancer, okay? And phase 1 is just about defining toxicity, okay? But sneakily, we do look for a signal as well. Are we getting a signal in a human being? Because preclinical is in a test tube, okay? If we get a signal and the toxicity profile is reasonable, we publish it in a peer-reviewed method, okay? So it gets published in a journal which is peer-reviewed, okay? And that's important. And if the signal is strong enough, it goes to phase 2, okay? So that drug then moves to another trial called phase 2 trial, where we now start looking at multiple cancers individually, testing to see if we get a signal. Does that cancer shrink because we give that drug, okay? And if the answer is yes, we're getting a signal, it gets peer reviewed and published. Then it moves to phase 3. And this is what I've said is registrational. This is where the trial then starts to come into the clinical arena, okay? The drug is tested on multiple cancers separately, okay, and compared against the current standard. And if the drug is better than the current standard gets knocked off its perch, and this new drug becomes the now standard, okay? And often we look at overall survival as the primary endpoint for these types of studies, okay? And if that happens, this is what happens then. That published paper then gets peer reviewed by the licensing committees, and that's the FDA and the EMA for that reported registration, okay? So that indication. And if that happens, then the commissioning bodies in each country decide whether they want to pay for that drug. And that is once again peer reviewed, okay? And that's how things enter into general practice, okay? Without this process of constant peer review, a drug won't enter into practice, okay? And this is the only way really to do this. So for lung nets, okay, if your methodology is not good, you're not going to pass your peer review in any of these steps. Look how much peer review we have to undergo, okay? So in order to try and improve methodology, we have to improve the pathway, okay? And really, I cannot see beyond centralizing it, okay? That not everybody should be looking after these rare cancers that can be difficult, okay? It needs to be a few who are specialized, okay? Research needs to be prepared so that it can pass reviewing scrutiny, peer reviewing scrutiny. There is no point doing a study which can't be published. Sadly, there's a lot of that going on, okay? We really do need to understand the disease at a molecular level much better. We really struggle with that, and that's because at the preclinical level, there aren't many scientists that are doing the work there.